Pat means reversal, which means regurg. And when there is regurgitation, we talk about that as well. This is the mitral, just above the mitral, and we were showing you about the tricuspid in that region. So once we are done with that, I don't know how many of you are doing doctor, then comes the ductus venosus. Ductus venosus has been already described this morning by Dr. Tossi, and I'll not take much of time. What I would like to say is that if your machine is switched to cardiac, fetal cardiac, you most of the time in the early pregnancy around 11 to 14 weeks, you may see reversal, which is normal. People call it as normal. They never realize that if you have done in the obstetrical setting, you never get reversal. So here is a picture. This is the umbilical vein, very easy to trace. Umbilical vein. Umbilical vein suddenly narrows, and we already described in the animation in the beginning that this sudden narrowing is deliberately done by nature, so that the blood coming from the umbilical vein produces a jet, so that all the oxygenated blood goes into the foramen vein rather than splitting and going into the right ventricle. So this jet is very important, and that jet is ductus venosus. Ductus venosus bypasses hepatic circulation, accelerates the blood from the umbilical vein to the foramen vein to the left atrium. That's the purpose of it, and delivers the oxygenated blood to the left side of the heart. That is the purpose. So here we have already described this point. This is the heart, and we were making the dotted line on this one, is to tell you that the flap of the tricuspid is 1 millimeter below the flap of the mitral, and if you draw a line, if you just draw a line, above and below would be giving you that information. Now, in order to get this picture, remember, very easy to do ductus venosus. For ductus venosus, look at me. These are the two hands. One is the urinary bladder and the other is the heart. Keep the heart away from the floor so the bladder will come front. The bladder will come near the floor, heart will go away from the floor. If you can produce that image, that's it. That's it. The reason is when you put your top cursor line just below the heart and increase the sample volume, you will get that. So you don't have to do color. Color will waste your time. And some people do it with color to see the jet, but I don't do it. Because then I have to switch, or I have to close that color and then go to a spectrum. I'm wasting my time. I don't do that. I'm going direct into that, and watch now. Now I'm on the fetal cardiac setting. Didn't I tell you that when you do ductus venosus on fetal cardiac setting, which you normally do for fetal cardiac, you miss that A wave, and you might get A wave inversion. You may overcall the reversal of A wave and diagnose tricuspid regurgitation or foramen vein is not A. These are the two major issues which you can diagnose on the basis of this. Now, just see what I do. The same patient I'm doing, and you can see the A wave is absent. The A wave is almost causing reversal or absence of flow. The same patient, when I change from fetal heart to the normal ops, because now I'm going to do ops, the whole scenario changes. This is a word of caution which I have pointed out to AIU people, the section meetings, that look, you are overblowing the whole situation and saying you can diagnose tricuspid regurgitation at 14 weeks. No, there is a problem there. Look at this picture. I'm going to show you. Same patient, same time. You can see there's no absence of that A wave, and his wave is not touching the baseline. There you can see this A wave is not touching the baseline. Same patient, same time. The setting has changed. There you can see. What did we do actually? What is the problem? what is that cardiac setting and off setting? In cardiac setting, the PRF is high. That is the problem which nobody knows. If PRF की setting इतनी high हुई है कि आप हर patient में absent diastolic flow create कर सकते हैं. ये भी any normal patient जिसका आपने umbilical cord ऑफर किया है, मैं उसका absent diastolic बना देता हूँ. This is the problem which very few people realize, those who are doing it. So there you can see the same patient, same time, there is no problem. And that's why people overcall. Did you turn on your obstetrical setting? If not, then you have. Okay, so color Doppler, echocardiography, and mode. I guess because of the time constraint, I want to go to the other portion of my fetal echo. But just to give you that M mode is part and parcel of your fetal echo. You know why? I'll tell you the reason why in a minute. There you can see. Can you see these dots here? We don't look at them. We are saying, oh, the heart is beating very good, and I'll put my pulse here and say rate is normal. We actually diagnose by these, and in absence of gap in that region on the top, that we say that it is tachycardia or bradycardia or skip beats and so on and so forth. We'll talk about that in a minute when we come to our last few slides. So keep your mind open with the dotted. There you can see. If I can show you, are you concentrating on these points right here? This is what we mean by the contractility of the wall, which will give you the evidence of the problem. So that's okay. And the beautiful left, the right ventricle, and there you can see these dots. So the contractility of that has to be picked up by these animals. But it's essential part of our fetal echo. Okay, let's go a little fast, and if I can show you something more. And that's again the fourth chamber, the jugular arch, which you've already seen. So I'll skip that also because I've already shown you. I'll skip to the other portion in a minute. I'm trying to teach you a mode, but and that's the fourth chamber view of the heart. Now, fourth chamber view of the heart, when you bring colored out, make sure your setting is on fetal heart. Because if you're doing an obstetrical setting, you are going to misdiagnose and say regurgitation. So the PRF is very high in that situation for fetal. Now you can see the planes coming up, means from the atrium is going up, red, and when you twist the probe, angulate it, you will see the blue. That means the heart contracts, the ventricle contracts, and you see the two blues, which is the aortic and the pulmonary. So, by color we diagnose if there is a regurgitation. And to diagnose regurgitation, you must have the apical view. The more apical view you have, the more you are perpendicular to those valves, which is tricuspid and mitral. And there you can see the pulmonary artery, aorta, and the SVC. Beautifully demonstrated in this picture, which we call as the three vessels. Now, more elongated is the pulmonary artery. That's why you see more blue. The more rounded is the aorta. That means we're at 90 degrees. That's why you don't see color here and color here. But you do see, because the pulmonary artery, this is the classical three-vessel view, and that's the planes which are coming out from the ventricles, from the atrium into the ventricle, and you can see the valves opening properly. We call it as a beautiful clapping sign of the tricuspid and mitral. There you can see. Rotating aneurysm, right and left. Now, what is bradycardia? Bradycardia is heart rate of less than 100 beats per minute. Ultrasound we can do it with M-mode, beam which goes through the atrial valve and the aortic valve or ventricle valve. Complete heart block. The atrium and the ventricles are beating regularly but are completely disassociated. This is what we do in the M-mode. Sinus bradycardia, there is one-to-one relationship between the atrium and the ventricle. So this is what we talk about in bradycardia. When we talk about tachycardia, it is the sustained fetal heart rate greater than 180 beats per minute. In this, we have got three categories: atrial flutter, that is the atrial rate is frequently monotonous at 400 plus beats per minute. Then we have supraventricular tachycardia, one-to-one atrial ventricular conduction, and heart rate is 180 to 200 beats per minute. So that means you have to do your M-mode and make the measurement. And then we have got sinus tachycardia, one-to-one conduction, with sustained heart rate of 180 to 190 beats per minute with very little variability. These are the ways to make the diagnosis of bradycardia, tachycardia, and of course ventricular tachycardia. Give to the world the best you have, and the best will come back to you. And that's what I believe, that's what I मैं तालियां अपने साथ लेके चलता हूँ कि कहीं ऐसा ना हो कि ऑडियंस कम हो तो फिर